My name's Tim Chang. I'm an assistant professor here at UCLA. I work in neurology. So our lab mostly focuses on EHR and genetics, and I also see patients, Alzheimer's and movement disorder patients. So today I'll be talking just for some time about this positive unlabeled learning we've been working on to try to identify undiagnosed Alzheimer's from the EHR here at UCLA. So just briefly we'll talk about the background and the data set we're using, results, and some summary. Okay, so yeah, Alzheimer's disease is one of the most common neurodegenerative diseases. About 10% of people over 65 are diagnosed with Alzheimer's disease. This is expected to increase significantly by 2050. There is some genetic predisposition to this. So one of the most known and common risk factors is this ApoE4 gene. So this increases your risk to depending on the race ethnicity, actually, it's about 1.3 to 2 odds ratio. But we do know that Alzheimer's is underdiagnosed. So for example, we can look at the sensitivity of Alzheimer's disease diagnosis comparing like real-world EHR data, and if we look at those same people who have a diagnosis but are also in some longitudinal cohort study where there's a research physician diagnosing Alzheimer's disease, that's about 50 to 65%. And there are these racial disparities as well. So compared to whites, we do know that non-Hispanic African Americans, they're about twice as likely to develop Alzheimer's, but only about 30% more likely to be diagnosed in the EHR. And then Hispanic Latinos is about 1.5 times more likely, but only about 18% more likely to be diagnosed. So, you know, we recognize and have thought about there is, you know, EHR diagnoses are not always 100% accurate, but that's because we're working with the real-world data, we've been trying to understand this more. So that is a limitation of using EHR data that we recognize. But still, we think 50% sensitivity is pretty low. All right. So when we diagnose Alzheimer's disease, there's obviously in-person assessments. There's new blood biomarkers that can be done. There's new imaging that can be done and new treatments, actually. But there's also these more data-driven methods that have been developed. So one, obviously, main approach is using supervised learning to look at the EHR data. You have large sample sizes, but labeling can be expensive if you really want, you know, a physician diagnose or chart review diagnosis. That labeling can be expensive. Obviously, it's easy to look at ICD codes. So one of the papers in 2020 that has done this, they use supervised learning to try to, similar to what we're trying to do to detect unrecognized dementia. So they have these cohorts where they diagnose people with Alzheimer's or not, based on seeing a physician, and then they can look in the chart like the EHR at Kaiser. This was done in Washington, and they developed this, basically it's a logistic regression model, and they have an AUC here about 0.8, and obviously that sensitivity, specificity, it can change as you change the cutoff for this regression curve. It includes quite a few features. Many of them are medications. Some of them are outpatient diagnoses. Some are labs. You know, looking at it quickly, it seems easy to re-implement, but some categories may not be that easy. For example, are you on a depression medication? What does that mean? Which medicines do they consider as depression? So. Okay, then there has been some semi-supervised learning that's been done, particularly mostly using imaging. So there's a large data set that others have used called ADNI, and they have looked at this. They essentially do something called positive unlabeled learning. So with some self-training, and the point here is that this is only using imaging from this ADNI data set, and they showed that this is AUC, I believe, improves when they use their method to about 80% versus 73%, where they use a traditional kind of case control supervised learning framework. So there's a couple kind of limitations that we recognized previously. One is many of these data methods don't look at algorithm fairness. So how fair are the algorithms across different race ethnicity? And there's not as many people who are studied who are in understudied groups. So we were trying to use this positive unlabeled learning framework, which is a subclass of semi-supervised learning. And the idea here is that the learner really initially only has access to the labeled positive cases. And this kind of works pretty well in the EHR kind of framework, because when we diagnose patients, we give them an ICD code diagnosis, but we don't declare someone that they don't have these certain diseases, right? So there is a thought that there may be undetected or unconfirmed Alzheimer's disease, let's say, because those people just have not been diagnosed yet, right? We don't enter not ICD codes. Okay. So the whole idea with positive unlabeled learning is you see my mouse? No. Well, the idea is that you take some of those red cases from the unlabeled groups and try to move them back into the positive case examples, and then you rerun your classifier on those two more distinct groups, and hopefully that gives you better results. Okay, so there's kind of three sections to this. One is how we develop the model and what their kind of accuracy and AUC looks like. We look at fairness across different race and ethnicity groups, and then we tried to validate the model with different genetic risk factors. So we used the UCLA EHR here. So we have this DDR here, and initially we had, there's 19 million encounters with about 500,000 patients, but if we look specifically only for our age group cutoffs, so we have self-reported race and ethnicity, we have some EHR kind of features like you have to be in the system for 5 years, then that comes out to about 100,000 patients. And from those, we have a cohort that has genotype data, genotype array data. So those are these Atlas patients on the right there. And then on the left, these are the patients without any Atlas genotype data. So like I said, we were going to use the Atlas patients to do some validation. So those we kind of did we held those out. So on the left side, there's these non-Atlas patients. We'll go through kind of this workflow a little bit, but the idea is that we have these, we have a training, evaluation, and test set within the non-Atlas patients. We identify the best classifier, the best model, and then we evaluate our metrics, but then we bring that over also to the the Atlas patients to try to evaluate the genetic differences between these groups that we have. So this will become a little more clear as we go. So this is our initial table, mostly about demographics. So if we look at these non-Atlas patients, there's about 87,000 total. About half of them, a little more than half, are female. And then our race breakdown, there's about 12% Hispanic Latino, 7% African American as well. The labeled positive, so there's about 2,500 of them. 3,800 of them, so about a little more than 3-4%. And that's, if you can tell, if you remember, that's pretty low, right? That's about what we saw before. About 4% over 65 with Alzheimer's disease diagnosis probably should be like 10 at least. So this is low, but this is what we're working with. And then the unlabeled is the rest of the patients. We do, if you look, the female sex is about 65%. We do know that more females are diagnosed with Alzheimer's disease than males, so this is consistent with what we see. Okay, so this is our semi-supervised positive unlabeled learning framework. There's a few steps here. There's 4 steps. So in step 1 here, we start with the labeled positives and the unlabeled. So we use a generalized linear model. We have labeled positives and unlabeled, and the whole idea is we try to find these reliable negatives. So those are the patients that we think are most likely, with a high probability, should be your controls. So we find these reliable negatives. We use something called this probabilistic gap, which I'll show you. And then the next step is we do some more pre-processing to help with bias mitigation. The idea is we add these, in the pink and the light blue, there are these additional positives and additional negatives. We do that by different race and ethnicity thresholds, and we do that to try to get up to the expected probability percentage of patients that should have Alzheimer's disease. And then we have this final classifier, which is a general linear, which is actually, we changed this briefly, it's a GLM here, and then now we have a bunch of cases and a bunch of controls that we think are most accurate. And then we do some post-processing bias mitigation, where we try to optimize, again, the probability of patients that are predicted with Alzheimer's. So the issue is if we only have 5% cases, then we evaluate and check that in our predictions, then we probably only are going to have about 5% predicted positives. But the idea here is that if we do some post-processing, essentially we're changing the threshold of who we're calling positive, then we can get up to like 10% or 15%. So how do we do this though? How do we check this? So there's people have used something called silver standards. So these are proxy ICD codes for Alzheimer's disease. This is obviously easier than going back through everyone's unlabeled records and looking at charts. So these are the silver standards we've used, and others have used these as well, but they include other types of dementia. So for example, if you're diagnosed with dementia unspecified, many times those patients actually have Alzheimer's disease. And then if you're on medications we typically use for Alzheimer's disease but don't have an ICD code, then most likely you may have Alzheimer's disease also. So they're not gold standards or silver standards, so we use these. Okay. And then what we've tried to use is this probabilistic gap. So the probabilistic gap simply is the difference between the predicted probability of you being a case versus the probability of you being a control. The example here is that the red on the right side, these are all the labeled positives, and we could look at their probabilistic gap. And in this case, they're all above, let's say, they're essentially above 0. But then the ones on the left, those are blue, so their probabilistic gap is less than that. So these on the left are more likely to be reliable negatives. So that's how the probabilistic gap is used. And then step 2 is we try to add these additional positives and additional negatives. And we do this based on, so this is known as pre-processing bias mitigation. So we use essentially different probabilistic gaps for different races, ethnicities, so we can look at that more closely. And then this helps add these additional positives and negatives so we can reach the prevalence of expected patients with Alzheimer's disease. So what I mean by that is that this post-processing bias mitigation is something that some others have developed. This is called group benefit opportunity, or GBE. So if we look at this chart here, if we look at the labeled positive prevalence like we talked about, we break it down by race ethnicity, it's about 4 to 5% here. But if we include the labeled positives in those silver standards, then we expect that probability to be closer to 18 to 20% when we look at the EHR chart. So then the idea is that if our positive prediction rate in our model later on is 18, 20, 19%, it's not always going to be exactly the same, right? Because then we could calculate this GBE, which is just like 21 divided by 21.7, so a little less than 1. So we want that around 1. So, all right. So that's kind of the framework of how we've done this. It was a lot to go through, but it's comparing, we do compare to these traditional supervised models. There's kind of 2 of them where we look at a few risk factors or we look at more risk factors when we do some feature selection. Okay. So this is to show kind of what the numbers look like, essentially similar to the prior table. So if you look on the right side on the gray, these are the percentages of our labeled positives, and our PUL predicted prevalence is like this 18 to 20% here, and then if we add the labeled positives with the silver standards, that also reaches a similar number. So this was by design; it's not by chance. Okay, this is the main table we're interested in looking at. We're interested in looking at sensitivity and precision, essentially. So because there's less cases than there are controls. So if we look at this non-Hispanic white, these 2 top columns are supervised with the risk factors, and you can see that sensitivity is about 45%, but the precision can be quite low, either 30%, but it does increase to about 87%. But then with our SSPUL model, we can increase the sensitivity to about 80%, and I should do this, okay. About 80% here, and we could hold a similar precision, so 87 versus 80%. So similarly, we can do this. We can look at this in the African American group or the non-Hispanic group as well. Essentially, the baseline models, they have low sensitivity. They can get some high precision, but in our model, we can hold the same precision but get a higher sensitivity. So that was our goal, is to increase our sensitivity. Okay. So this is what the features look like. So this shows you the direction, but as you can see, some like age is important, aphasia, vascular dementia is important, this mild cognitive impairment. Some interesting things are negative risk factors. So for example, shortness of breath or dyschromia as well are negative risk factors. So one of our questions was, what's unique about these new additional positives we're adding to do additional, to help the model learn better. So in this kind of dimensionally reduced space, the red are the positive labels and the blue are the predicted negatives. And the orange here are all the predicted positives. So our question we were thinking about is like, what's going on with these patients who are predicted positives, but they don't really overlap with the labeled positives or the predicted negatives. So maybe there's something unique about those patients that is helping the model learn better. So we were trying to look into what's unique about them. We can look at this, this factor analysis as well, but I think it's easier to show in this next figure. So if we look at those group of patients, there's some diagnoses that are higher in this group versus the labeled positive. So for example, more of these patients have chest palpitations, they have more mental health issues, major depression, and they have, for example, urinary tract infections. So these are patients we think are in a different feature space than the labeled positives. And they have different features that are able to, that are more beneficial to help identify if these patients may have undiagnosed Alzheimer's disease. Versus if you look at kind of the traditional risk factors, like vascular dementia or MCI, the labeled positives have a lot of these because we knew those were high importance features, but this kind of subset of the non-overlapping predicted positives don't have as much prevalence of that. Similarly, we can identify these. We can also look at this based on SHAP values as well. So this was the original. These are those like urinary tract infection features. So there's more contribution based on SHAP analysis to identify these urinary tract infection features as important compared to the labeled positives down here. All right, and when we look at fairness, there's I'll show you this table first, but the idea is we're comparing non-Hispanic African Americans to non-Hispanic whites and Hispanic Latinos to non-Hispanic whites. And the way this is typically done is that for any of these equal opportunity precision, you essentially take the value for African Americans and subtract it from the whites. So the goal is we want those to be similar. We want them to be, so then they can be fair. So we want these values to be as close to 0 as we can. And as you can see, if we look at the supervised, there is some variability based on many of these metrics from, let's say, 4 to 8%. But then mostly, if we look at our SSPOL models, there's much less variability between race and ethnicity for these measures. Similarly for the Hispanic and Latino. Granted, this is smallest at like 1%, but this is only slightly higher. So that was partially what we wanted to achieve as well. We can also look at this in another way. This is looking at our GBE cutoff, and we wanted GBE to essentially to be 1, so it's basically 1 for our GBE models that we use. And then there's also another metric called the cumulative parity loss. So what you can do is you essentially add all the differences between these different metrics together to get kind of a summary overall contribution of how much difference this parity loss is. And you can see that this SSPOL, you want this total number to be low. So this one is the lowest for SSPOL. All right, and the last few slides, we were looking at polygenic risk scores in this APOE. So we'll start with APOE here on the right. So APOE4 is a risk factor for Alzheimer's disease. So what we essentially looked at is if you have, this is the number of E4, like the average E4 allele count for different groups. So the labeled positives, predicted positives, and the negatives. So we can look at this overall. It makes sense the people who are labeled positives, they're more likely to have this E4. We know this was a risk factor. And it's good to see the predicted positives, they're not as high as the labeled positives, but they are higher than the predicted negatives. So this holds true for different race and ethnicity categories. We also looked outside of E4, the APO-E4 region, and we look at this polygenic risk score as well. And a similar trend holds here. Yeah, so I think in summary, this SSPOL we developed helps to limit some of the label bias and some of the expense of supervised learning. We did these two types of bias mitigation, pre and post-processing bias mitigation. We showed that these were better than some of the supervised model based on traditional metrics and also based on fairness as well. And that there's interesting predictive features for different sets of these positive patients. And genetically, we also see validation with our results as well. So that's it. A lot of this work was done by a grad student, and thanks to a lot of the different funders. So yeah, happy to take questions. I guess we have a few minutes left.